Thank you, Rohini. Next, we have a predoctoral fellow at the NCI, Natalie Pritchett, and she's going to be presenting Citizen Scientist Monitoring Project of Polycyclic Aromatic Hydrocarbon Concentrations in Bomet County, Kenya, a region with a high incidence of esophageal squamous cell carcinoma. Thank you.
Okay, so thank you for that introduction. Like she said, I'm a predoctoral fellow at George Washington University, and I'm also working at the National Cancer Institute. I'm actually currently studying, I'm skipping out on class right now, so hopefully my professor will forgive me. A little bit of background about esophageal cancer. In the area where we work in Bomet County, where we partner with Tenwick Hospital, esophageal cancer represents 35% of all malignancies. It's the most common cancer that they see. And I believe in the most recent Cancer in 5 Continents study, it was actually shown to be the #1 most fatal cancer in Kenya. Of these, 90% are the squamous cell carcinoma subtype. It's fairly equally distributed among men and women. Normally the ratio is about 2 to 1, and in this region you can see it's more like 1.6 to 1. And most unique about this area, and most concerning probably, is the very young age of cases that present in this area. Almost 10% are less than 30 years old, which is totally unheard of in other areas, such as China, where they see some of the largest number of cases in the world. They never see patients this young. This is a new discovery. This is a map from the 1970s by Dr. Dennis Burkett, mapping out the esophageal cancer cases. And an interesting fact for me, I'm actually studying environmental health, and the geographic distribution that you can see here with these unique hotspot regions around the world, and especially in this region, suggests the contribution of an environmental risk factor that maybe is unknown or has been underestimated up to this point. So that's the part that I'm interested in looking at. One of the leading suspected risk factors for ESCC is polycyclic aromatic hydrocarbons. These result from the incomplete combustion of organic carbon. But the sources, intensity, and behavioral factors contributing to this exposure are not fully understood. Some of the possible sources you can see up here include crop fires, tobacco smoke, coal smoke, car exhaust, but in this context, what we're actually most interested in is probably indoor cooking exposure. So this is actually a proposal for a project where the primary aims would be, can community monitoring of indoor air pollution be conducted by individuals in their own homes in rural Western Kenya? What are the key factors driving exposure to indoor air pollution? And then can a statistical model be built to predict exposure to indoor air pollution? Following up on this with the citizen science angle that I'm also very interested in, the sub-aims would be, can in-home PAH monitoring increase awareness of indoor air pollution? And also, does the use of improved cooking stoves, which is also being implemented currently in some homes in this area, reduce exposure to indoor air pollution? So in order to do this, we've teamed up with the Tenwick Hospital. There they have a community health and development department that's been working since the 1980s. So they have a very close relationship with the local area, and they've also helped out with a previous study where they conducted a community endoscopic screening. So the community is very aware of the problem, and they're also very interested in trying to find ways to prevent this disease. So the method that I'm proposing for this project is actually using silicone wristbands like the one I'm wearing right now. We probably all have something like this. It can be used as a passive sensor to pick up particles. It can include anything like pH for this particular part of the project. It could also collect pesticides or other chemicals found in the environment. This is a great tool to try to utilize because it doesn't require battery power or any kind of maintenance. So I think this would be a great way to try to get this out in the community. This is not totally novel method. It has been used previously in other studies that I know of. In Peru, there was also a project in West Africa, but I think this is unique because it hasn't been done in a region with a known high risk for a specific cancer to link back to these risk factors. So for next steps, as we roll out this improved cooking stove project, we hope that this can provide the data to demonstrate the benefits of the project. And we also hope by developing a predictive model, it can help provide information about who is at greatest risk of being exposed and also suggest future areas for intervention. So I'd like to acknowledge all of our partners in Bomet, Kenya, the Organic Analytical Toxicology Lab at the CDC, as well as the Metabolic Epidemiology Branch at NCI, where I'm a fellow. And I would especially like to highlight Dr. Michael Mwachiro, who unfortunately you probably can't see in this image because it's too small here, but he's an excellent young leader in cancer research, and I really hope he can be involved in future efforts with ICEC. So I definitely would recommend him for being a part of this organization. So thank you.